Okay, so thank you for the invitation. I'm Sarah Wannez. I'm a member of the team of Professor Wannez in the Coma Science group. So today I will talk about the brain disorders, the brain function in disorders of consciousness. But before talking about disorders of consciousness, I would like to talk a little bit about consciousness. If we try to explain consciousness, we can reduce it into two dimensions, two components. On one hand, we have the awareness, it's the content of the consciousness. And on the other hand, we have the wakefulness, so the eye-opening. When you are fully conscious, like now, I hope, you are in high level in two dimensions. From deep sleep to conscious wakefulness, you can experience different levels of wakefulness and awareness. During lucid dreaming and REM sleep, your eyes are closed, but you are conscious, so it's a dissociation. In coma and general anesthesia, the patients are completely unconscious and the eyes are always closed. But sometimes patients have eyes opened, but they are not conscious. We call this the vegetative state. But now we use unresponsive wakefulness syndrome because it's less negative than vegetative state. This dissociation between wakefulness and awareness is also observed in the case of epilepsy and sleepwalking. When the patient regains some subtle signs of consciousness, he is considered in a minimally conscious state, MCS. If he is able to follow simple commands, he will be considered in an MCS plus. And if he only shows non-reflex movements, such as localization to pain or visual pursuit, he will be in an MCS minus. Finally, locked-in syndrome is a rare condition after a coma. It's due to a specific lesion in the brainstem. The patient is fully conscious but completely paralyzed. And the classical way to communicate with this patient is the vertical eye movements. For a long time, we have thought that consciousness was due to the entire brain. So when we looked at the metabolism of fully conscious people, we saw that all the brain was activated. At brain death or during general anesthesia, the metabolism was very low. It was the same in the vegetative states, but when patients recovered from vegetative states, so unresponsive wakefulness syndrome, the metabolism didn't increase so much, so we thought that maybe consciousness was due to specific areas in the brain. And that's why we observed, because consciousness, awareness, can be subdivided into two components. On one hand, we have the self-awareness, so it's the self-consciousness, the little voice in your head. And on the other hand, we have the sensory awareness, it's the consciousness of what is happening around you. Internal awareness is supported by a median network composed by the anterior and posterior cingulate cortices. External awareness is supported by lateral frontoparietal networks. What's important is the connectivity within these networks and between these networks and the thalamus. These two awareness are anti-correlated, so the more you will be focused on yourself, the less you will be conscious of what is happening around you. And it's reflected by the activation and deactivation of the two different networks. So let's remind a little bit the different states of disorders of consciousness. First, we have the coma, so the patient is fully unconscious and never opens the eyes. When the patient opens the eyes but still remains unconscious, he is in a non-responsive wakefulness syndrome. When he is able to show some subtle signs of consciousness, such as visual pursuit, localization to pain, or appropriate crying or smiling, he is considered in a minimally conscious state minus. So these patients are not able to answer, to follow simple commands. And we see in the cerebral metabolism that the left hemisphere is hypometabolic. When patients are able to follow simple commands, they are in an MCS plus. And then we do not see anymore an hypometabolism of the left hemisphere. Finally, when the patient is able to functionally communicate or to functionally use different objects, he is considered as having emerged from the minimally conscious state. Okay. So these different states are not always easy to distinguish, but it's really important because the patient can be conscious or not. The first tool that we have is the clinical assessment. So on more than 100 patients, Caroline Schnackers asked the medical staff which diagnosis they would give for each patient. 45 patients were clinically considered as unresponsive by the medical staff. When she assessed them with the Coma Recovery Scale revised, that's a standardized behavioral scale that is really that permits to differentiate unresponsive and minimally conscious patients. 18 of them were minimally conscious, so it represents 40% of misdiagnosis. The Coma Recovery Scale revised is composed of 6 subscales, which assess different functions. We have auditory function, visual function, motor function, oromotor and verbal function, communication, and arousal. So you have several items to test with the patient to see if they are conscious or not, and one of them is the visual pursuit. But we have shown that it was better to test visual pursuit with a mirror because it was more efficient than an object or than a person to detect visual pursuit. Maybe because this device is more autoreferential. Response to command is also a good sign of consciousness, but it depends on motor skills, and we know that our patient can suffer from motor impairment. So the first study that tries to detect command following without any motor interface used the functional magnetic resonance imaging. We tested 54 patients, and we put them in the scan, and we asked them to imagine playing tennis or to imagine navigating in the house. And 5 of them were able to do the task, so to imagine playing tennis. We saw the activation of the premotor supplementary area or the para-hippocampus gyrus. But more interesting, with one of these patients, we were able to communicate. So in the scan, we asked him some simple questions like, is your father's name Alexander? If you want to say yes, imagine playing tennis, and if you want to say no, imagine navigating in your house. He was able to correctly answer to 5 questions out of 6, and this patient was completely unresponsive at the bedside, so it's really, really impressive. But once he's back in the room, he cannot communicate anymore, so we tried to develop other devices to permit communication without motor interface. This is called brain-computer interfaces, and we made one with the EEG. So the same protocol was used with the patient. We asked them to move your hand or your feet. Out of 16 unresponsive patients, 3 were able to do the task, so it's really impressive. Unfortunately, the problem with this technique is the rate of false negative, because out of 23 MCS patients, so minimally conscious patients, only 7 were able to do the task. We can also use the eyes to communicate. When you are stressed, your pupil dilates. So we wanted to stress the patients, and we asked them to solve equations. When you try to solve equation, your pupil dilates. So we asked them some question, and then we proposed subsequently the 2 possible answers, so yes and no, with calculations, and they had to solve the one that they want that was linked to the good response. We made it with locked-in syndrome patients, so they are fully conscious, and they were able to communicate with this system. With one minimally conscious patient, we tried the communication, but it was not possible because this patient is not conscious enough to communicate. But he was able to follow the command, so when we asked him, please solve the equation, he made it and the pupil dilated. So response to command also relies on language comprehension. You have to understand what the other wants from you. But we know that our patients can also suffer from aphasia. So we use the fMRI to assess the brain connectivity within the default mode network. This is a set of brain areas that are activated when the brain is at wakeful rest, during mind wandering. And we saw that in minimally conscious patients, the brain connectivity was very lower than locked-in syndrome patients, so control patients. In vegetative states or unresponsive wakefulness syndrome, it was even worse, and even worse in the coma. The connectivity of the precuneus was more present in MCS patients than in unresponsive patients. Here you can see the integrity of the functional integrity of the default mode network in a control and in a locked-in syndrome patient. So it's really as conscious as the healthy controls. And you can see here the hypodensity due to the brainstem damage. We can also use the PET scan with a radioactive glucose to assess the metabolism of our patients. In unresponsive patients, we see an hypometabolism in the two networks that we spoke earlier. So the lateral frontoparietal network and the anterior and posterior cingulate cortex. In MCS patients, only the internal network was hypometabolic. It represents the self-consciousness, so it's really difficult to assess at the bedside of the patient. Moreover, the authors tried to correlate the metabolism of the brain with the total CRSR score, so the behavioral scale that we use at the bedside of the patient. And she showed that CRSR score were correlating with the posterior cingulate cortex and the lateral prefrontal, parietal and frontal cortex. Recently, a study compared the congruence between clinical consensus, so the medical staff says, okay, the patient is conscious or not, and the diagnosis that we obtain with the CRSR. They also compared the CRSR with the PET and the fMRI. They showed that we still see 35% of clinical misdiagnosis. So medical doctors are wrong in 35% of the case. They also compare how many patients were considered as unresponsive by the CRSR, but were considered as minimally conscious by our neuroimaging tools, and it reached 32%. So it's pretty high. Another way to assess consciousness without demanding the patient to understand or to do something is the EEG-TMS, the transcranial magnetic stimulation with electroencephalogram recording, a 64 electrode setting. So you send a pulse to the brain of the patient with the magnetic coil, and with the EEG you record the propagation of the information. In case of unresponsive patients, the response is very local and very stereotyped, and she stops quickly in the time. In minimally conscious patients, the response is a little bit more complex and a little bit more widespread than in unresponsive patients. Finally, locked-in syndrome patients has response as complex as the healthy controls, as expected. They also followed patients from the unresponsive wakefulness syndrome to the recovery, and they saw that across the different stages, the response changed. But all this relies on the visual appreciation of the response, and it's purely qualitative. So some authors wanted to quantify the complexity of the brain response. And they developed an index that we call the Perturbational Complexity Index, or PCI. And you can assess the response of the patient. So with fully conscious individuals, the PCI was within a range, a distribution above 0.45. When subjects were unconscious during sleep or during anesthesia, PCI was always below 0.31. So it's a way to quantify consciousness. And we tried on our patients. Unresponsive patients always had PCI values under 0.31. Locked-in syndrome patients had value in the range of the fully conscious healthy controls. And minimally conscious patients had values between the two distributions. So it was always above 0.31, but mainly below 0.44. Another important aspect of the treatment of the patient is the pain, because we cannot let them suffering. When we ask the doctors if they think that unresponsive patients can feel pain, they do not all agree. Religious caregivers are more likely to think that they can feel pain than non-religious caregivers. But how can we assess pain with non-collaborative and non-communicative patients? We developed the Nociception Coma Scale Revised, the NCSR, that assesses motor, verbal, and facial responses. If the total score is superior to 3, the patient is considered as suffering, so you have to give him analgesic treatment. But how can we really know if patients feel pain or not? We put minimally conscious patients in the scan, and we looked at the brain region that they activated. And some of the regions were the same than healthy controls, so they might feel pain as well as we do. So it's really, really important to give them an adequate treatment and not to let them suffer. But what about the treatment of the disorders of consciousness? One patient that spontaneously recovered from the unresponsive wakefulness syndrome recovered the connectivity between the thalamus and the frontal areas. So Nicholas Schiff in New York implanted an electrode into the thalamus of a minimally conscious patient, and he stimulated the thalamus. After this invasive surgery called deep brain stimulation, the patient was able to functionally communicate and to functionally use objects, so he has emerged from the minimally conscious state. It's promising, but it's a little bit invasive. So we tried another way to treat these disorders of consciousness, which is the transcranial direct current stimulation, the TDCS. It's not invasive at all. It's only 2 electrodes on the scalp of the subject, 20-minute stimulation. And Aurore Thibault made this stimulation on unresponsive and minimally conscious patients. And she showed that unresponsive patients didn't benefit really from the stimulation, but MCS patients had higher CRSR scores after the real stimulation. And it was really due to the stimulation, and it was not observed during sham session. Moreover, 43% of the patient, the minimally conscious patient, showed a new sign of consciousness after the stimulation. So it's really, really impressive, just thanks to 20-minute stimulation. Regarding ethics, we have to face some issues like end of life. When we asked medical professionals if it was acceptable to stop the treatment in chronic patients, they didn't all agree, and for unresponsive patients, it seems to be more acceptable than for minimally conscious patients. Moreover, North countries seems to be more likely to accept this than Southern countries. Regarding quality of life, it's not easy to assess with our patients because they are not communicating at all, but we made it with the locked-in syndrome patients, so patients that are fully conscious but completely paralyzed. We used this scale, the AXA score, so -5 is the worst period in your life, and +5 is the best period in your life. So your scale is calibrated, and you can say, okay, for the 2 last week, I was moreover at -1 or +3. So you can think now about your AXA score. And then we will discover the response of the locked-in syndrome patients. One should expect that as they are fully conscious but paralyzed, they are not very happy. But the results are quite impressive because most of them were pretty happy and they were not all depressive. So to conclude, I would like to recall that awareness is supported by two networks, self-consciousness by the internal network and sensory awareness by the external networks. What is important is the connectivity within the networks and between the networks and the thalamus. Regarding diagnosis, we have seen that it's not always easy to distinguish these different states, and that it's better to use a standardized behavioral scale, like the CRSR, to decrease the rate of misdiagnosis. Moreover, we have to use our neuroimaging tools and our BCI in order to detect consciousness, even if the patient is aphasic or motor impaired. Regarding treatment, we have seen that it's really, really important to treat pain and not to let patients suffer. And for the treatment of disorders of consciousness, we have seen that deep brain stimulation is promising, even if very invasive, and TDCS can be also very useful. We also have to face some ethical challenges, such as end-of-life issues. So from coma to full recovery, we have to use all the tests that we have, all the neuroimaging tools, all the devices that we have in order to detect awareness as soon as possible and to facilitate communication in patients who are motor impaired. But some patients fully recover from the coma, and after, they said that they have memories from the coma. It's called the near-death experiences. In our group, some people are working on this and try to better understand this phenomenon. So most of the time, near-death experiences are positive. Here are the dimensions that the people report. So it's peacefulness, out-of-body experience. So you see yourself from the sailing, for example. Happiness, unearthly environment, but it's really positive. In dark gray, you can see the retrospective studies. So patients have been interviewed several months or years after the cardiac arrest. And in light gray, the prospective studies. So right after the cardiac arrest, they have been interviewed about what they have lived during their coma. And we see that when you ask the patient if it's just after or long time after, it can influence some dimensions, so they do not report the same thing. If you have lived any near-death experience, please feel free to contact us and help the science. Thank you very much.
Thank you very much for the talk. Questions? So I start with one. You show that you can use fMRI and resting state connectivity as an indicator for the level of consciousness. How can you contrast it to the TMS EEG method, which is more perturbative? Isn't it more complicated?
More complicated?
More complicated, requiring an action, requiring to combine TMS and EEG, compared to fMRI, which maybe is available at all facilities, all diagnostic facilities. Do they have the same power?
It will be published soon, but no, they clearly do not have the same power, because fMRI needs the patient to be completely immobile, and clearly with non-collaborative patients, it's not always possible. So you cannot make fMRI with moving patients. And TMS, for example, needs with TMS we cannot test patients that are epileptic, because we send some impulse in the brain. But PET scan and TMS tend to be more or less powerful, but it will be published soon, so it's not yet here.
Thank you very much. Any more questions? If not, let me thank you again.